of Medical Monday. Everyone looks so nice in their red. And before we get started, I did want to, the reason we wear red is heart disease is the #1 killer of women. And so we want to always recognize that. Our guest speaker today is Craig Kinyon, who's the CEO and President of Reid Health. And first, Craig's going to give an update on some different things that's going on at Reid. And then we'll open up the floor. And also, I want to recognize that we have a Reid Health Governing Board member present, Elisa Stewart.
And she's also a member of our Community Benefit Board Committee. Always happy to have her.
And remember, community benefit pays for Medical Monday and our lunches. Okay. So now, present Craig Kinyon.
Thank you, Sherry. It's great to have you all here. It's this nice, dry place to be on this wet, rainy kind of day we're having. So pleased that you all came here and looking forward to a great discussion. As Sherry said, I'm going to go through just a few things to maybe get things started. She told me I don't really need to nudge this group too much with questions, but sometimes we need to get things rolling a little bit. So I'm just going to give you an outline on a few things here, then put this down, and we'll just talk on things that you want to talk about, things I can help answer or help address. Does that sound okay? All right, great. First one is, time flies. We're already now into 2020, and come July, it'll be 1 year since we've been at Connorsville. And that was a rapid process. I remember 1 year ago today, we're just really getting started on what's happening down in Connorsville with the big changes they had when they had their bankruptcy filing. So we were moving very quickly to get into that transition with them. And it just was a totally different process than we thought. There was supposed to be an auction, and there wasn't an auction because we were the only ones at the auction. And so we cannot let that community go without basic medical services, which they were going to be without come middle of July. So we quickly put together a plan to go down there, and it's been nonstop since we arrived down there on July 16th. So come July 16th of this year, it'll be 1 year since we started up there, and there's just been a tremendous amount of work to do. The people on there have been just fantastic, absolutely great people to work with, and we enjoy all the friends we've made in the whole transition. A whole new group of Reid team members came on board, and we're just thrilled to death with their passion and their support for their community, so it's great working with them. The PACE Clinic, so if you've been over on the west side of Richmond lately, you've seen where County Market or Cub Foods used to be, that we've been upgrading that facility to make it available for PACE. We actually have ownership of the entire strip mall there, and there's some additional spots we're also leasing out, but we also paved the parking lot, and pretty soon we're going to take down that old Pizza Hut building. That's going to be on its way down here shortly, and just continue to try and spruce that area up a little bit. So we're happy to be there, happy to kind of transform the image of that a little bit. Also in the news a few months ago was the transaction, I call it a transaction, that we had with Forest Hills Country Club. And backing up a little bit, one of the most important assets we have at Reid are our physicians. As I tell all of our new hires, without our physicians, Reid would be a hotel with good food because that's all we could do. We couldn't treat patients, we couldn't start care, we couldn't continue care, and we couldn't stop care unless we have physician orders. Even our advanced practice providers, which are nurse practitioners, physician assistants, midwives, all of them still need to have a supervising physician or they can't practice. So our physicians are the lifeblood of what we do, and we need them. So we have 3 people full-time that do nothing but recruit physicians. That's all they do from January through December. So we know that every physician we get at Reid comes at the loss of 1 or more communities that wants that physician as much as we do. So we know that recruiting physicians is a full-time task. Now, one of the ways to take some pressure off of physician recruitment is through physician retention. So if you're not turning over your physicians, and they're a lot more mobile now that they're employed rather than the old days when they used to be in private practice. So if you can decrease the retention, then you can take the pressure off the recruitment. And one way to increase the retention is through resilience. In other words, physicians are under a lot of pressure. There's all the things that they're supposed to do as physicians, and then there's all the other regulations we ask them to comply with. A lot of things that actually take them away from working with all of you. The things they need to do for fulfilling the compliance and the regulations to provide care is less time they spend in the exam room with their patients, and they don't like that. That is really something that eats down at their resilience. So keeping their resilience high is important for us. One of the things that really feeds into a physician's resilience is their interactions with other physicians. Little did we know that when the market changed, not just here, but across the country, and our physicians came to us back about 12 years ago and said, you know, we just can't make it anymore. We're working longer hours, working weekends, paying all the bills, paying the staff, and some have said, I'm making 30% less today than it was 5 years ago. So that's a real pressure issue for physicians, because if they can't economically survive, they'll leave. And that's exactly what they told us. So that started the whole transition of Reid purchasing the practices of the physicians, because they came to us and said, we want you to do that. And that was the beginning of a steady stream of transitions all up and down Chester Boulevard of all the physicians that came to us and said the same thing essentially to us, which was, if you don't buy my practice and employ me, I'm going to leave to somewhere where I can be employed. So that started that off. So part of the unintended consequence of that was the physicians that stayed as outpatient only never went into the hospital. And then we had hospitalists, the hospitalists that see our patients when they come in to be admitted as inpatients. So back years ago, that was your family doctor when you saw that family doctor in the office. And then if you came into the hospital, it was your same family doctor that saw you when you came into the hospital. And that changed also about 12 years ago when physicians couldn't keep doing the call, the nightly call and the weekend call. So they said, make me outpatient only or make me a hospitalist only. So when you think about that, the interactions between physicians almost virtually stopped. So we had people that left their house in the morning, would go to their practice, see patients all day, leave their practice, go back to their house. The hospitalists would come to the hospital, see patients in the hospital, finish their shift, and go home. In the old days, the beehive of activity was the medical staff lounge. Physicians would show up around 6 o'clock in the morning, would round on patients till about 8:30, hightail it back to their offices to see patients, would get calls from us all day about the status of the patients, changes in medications, changes in labs, and then they'd hightail it back from their office up to Reid to see patients from about 5 to 8 o'clock at night, and then to go home to their family. And they did that, but they saw each other a lot in the Med Staff Lounge. The Med Staff Lounge was our version of Grand Central Station. It was the busiest place in the hospital. So the challenge for us is how to build resilience. So we started by reformatting and changing the medical staff lounge and brought in, of all things, food. Food's a great attraction. Bring in a breakfast item and giving people a reason that even though they're going to go work at their physician office, don't eat breakfast at home alone. Don't eat breakfast at the McDonald's drive-thru. Come on in and see your colleagues and talk with them. And we weren't sure exactly how that was going to go over, but that went over absolutely wonderfully. And they all show up. So that is another way of building resilience. When physicians talk with other physicians, interact with them, that takes them back to the way they were really brought up in the medical community, back when they were in medical school, back when they were residents, and back when many of them were in private practice going to that Med Staff Lounge. So building resilience in our physicians to decrease the need for, to increase retention and decrease the need for recruitment started this whole notion going forward on what to do with their families. And that gets into Forest Hills. So Forest Hills has been in need of some upgraded projects. So our transaction with them was we're going to prepay and buy family social memberships. So as a benefit, or a fringe benefit if you will, to employed physicians, we will give them a membership for family social membership. That does not include golf. That's just going there in the summertime by the pool. That could be eating dinner with family, friends, and so forth. But just to get them to gather more as families and physicians, to meet other families and physicians, to build their resilience, to really spread their roots deeper into this community. More reasons to stay as opposed to more reasons to leave. And believe me, they get phone calls and emails all the time about jobs somewhere else. So we have to give them more reasons to stay here than to want to be somewhere else. And we approached them with the idea, our physicians, about that, and they thought it'd be a good idea. So we have worked with Forest Hills to pre-buy a block of family social memberships. Now, the IRS gets involved with that, so they're going to pay the IRS taxes on that as a form of compensation. If they want to buy food, they're going to pay that out of their own pocket. So they'll use that facility for gathering, meeting with friends and family and so forth. So we feel that's another opportunity to build resilience for our physicians. So that's a quick thing on Forest Hills. Medicare Advantage plan. We started the Medicare Advantage plan here at Reid a few years ago, but Medicare Advantage is not new. That's been around for a long time. The different players in that, you probably know them. You see the ads on TV and the commercials on the radio as I do. There's a lot of players, Anthem, United, Aetna, so forth. So working with our partners, Reid Health Alliance is our program to have a more tailored program that we think goes above and beyond what the other plans do, and to bring that back locally. So that was appealing to us rather than signing these managed care contracts, because when you go with Medicare Advantage, you're not working with the government, you're working with an insurance company. And you have to have a trust and relationship with that insurance company and how they're going to handle your patients. So we felt to have a program that we were more partnered with was the better approach for us in going down that road. And I'm going to jump around here. We can come back to any of these items you want to come back to. Community benefit. There's a lot of things going on in community benefit. I would say from my almost 25 years here at Reid now, community benefit has just been a growing and growing and growing process that's gone well beyond the boundaries of Richmond, has gone well out of the county boundaries of Wayne County, and is now enveloped into 8 different counties on different activities that we have. I look at it this way. An easy way for me to explain community benefit to somebody that wants to know what that is, it's another way that we reach out to care for people outside the walls of Reid. In other words, how people are able to be ministered to, cared for, given information, checked on, and so forth outside of Reid feeds into the strategy of ours of keeping people well and at home. So management of chronic disease, whether that's unmanaged diabetes, congestive heart failure, COPD, or other conditions that get out of hand, a little hard to manage, and some people need some help to know the warning signals. So we have set up a variety of different ways to address that, and community benefit is just another layer of us also interacting with other agencies within our community service area. So in other words, we don't have to be all things to all people, but we'd like to partner with other agencies that are already doing good work in the areas of the community that they exist in. So that's community benefit. It's hard to really explain in a nutshell, but that's probably the best explanation I can give you as to what community benefit is. And it will change and grow as we see the needs unfolding. So it's a large partnership of Reid and other community providers, and Reid providers as well, coming together to help improve the health of our communities. Another thing that came up, penciled this one in, was dress code. Some had concerns about the dress code at Reid. And I would say from time to time, I have concerns about the dress code at Reid. So this is something that happens from time to time that we have to, acquaint everybody with our policy. So Reid has a very strict policy on dress code. So I would tell you, you all know how to get a hold of me, and if you don't, Sherry knows how to get a hold of me. If there's something that specifically concerns you in an area about how somebody's dressed, I certainly want to know it, because our supervisors are supposed to be watching that, because people test the system. They go along with one way, then suddenly one day they come in and test it, and if we don't catch it right there, then that becomes, well, if they're doing it, then I can do it, and it starts to spread pretty quickly. So if you see that, I want to know, because we need to remind people there's a reason we have a dress code, and there's a reason that we want to enforce that. It wasn't too long ago, it seems like years ago, but it wasn't too long ago, that we would not let people have exposed tattoos. So people that had tattoos on the wrist, if they were in an area where somebody could be seen from the public, they had to cover that. And so that just became a little harder for us to find people to recruit. And we're also trying to reflect what we see happening with the entire community, not just here, but seemingly in a lot of communities around the country, that tattoos right now are just a different way of expressing, another way a person can show the way they like to dress or present themselves. So we're coming to terms with how we can balance that in. And I would tell you, not every single tattoo is going to work. So there's still some that we just can't bring on and employ, because our goal is to make sure that we're not presenting a bad image to all of you as our patients. So you all kind of become our bellwether on this, but we had to balance that with what we're seeing with the changes in how people are presenting. So those are my, I think, 6 items that I was covering right off the bat. But I'd be happy to take on any additional questions you may have on what I shared. I can go back and talk more about those, or anything else that you have on your mind that you'd like to talk about. Okay?
The shortage of doctors in everybody. When you call to make an appointment, you guys have a good nurse practitioner, but I expect to see a doctor, not a nurse practitioner. So, I mean, we saw it was coming, so what?
Yeah, nurse practitioners and physician assistants are not new. They've been around a long time, but they are now becoming more integral into physician practices. In other words, physicians themselves had to first accept their roles in what they do. So a nurse practitioner or a PA working with a physician are part of that physician's team. In other words, that physician wants them there. So if you think about what a nurse practitioner does, a nurse practitioner does not do everything a physician does. So there is a certain level of care that a nurse practitioner can do extremely well, or a physician assistant can do extremely well, or a midwife can do extremely well. And the physician still supervises them. So they're still responsible for everything they do and how they do it. So they are accountable to their physician. So the physician identifies the level of services that particular nurse practitioner or PA is capable of giving. So let's say around this time of year, when there's a lot of viruses going around, a lot of people will come in with feelings of, I'm not sure if this is going to be pneumonia, I'm not sure if this is a virus, I'm not sure if an antibiotic will be effective, and so forth. And those calls start coming in. A lot of physicians will have those calls be scheduled with a nurse practitioner or a physician assistant, because a lot of times it's ruling out whether it's a pneumonia, which they're very capable of seeing if there's listening to the lungs and hear if there's something going on in the lungs. So we're very concerned about pneumonia. Second thing is, are we seeing symptoms that are similar to a virus, or are we seeing symptoms that really maybe looks like a virus, but there's a lot more going on, potentially an infection involved? And then we may get some blood work going on. At a certain point, a physician assistant or a nurse practitioner, if they feel this patient's getting more complex than they originally thought, and this is their patient to see today, that nurse practitioner or PA will go out and talk to their doctor, their supervising physician, about what's going on. And if that is an issue that this says, this person is a lot more complicated than we thought, the physician will come into that room and finish the appointment with that patient.
So is he there just to supervise you know, if I call and I make an appointment, who decides that I see a nurse practitioner, the girl on the phone, or who? I mean, you know, like, my records were turned over to the nurse practitioner.
No.
I want the doctor, you know.
Yeah, your physician makes the determination of which patients that nurse practitioner or PA is going to see. Now, in the explanation from one physician, actually wrote a book on this. The way he described it in his book was, during this time of year, we see a lot of viruses and flu symptoms and things like that. They'll schedule those calls based on the symptoms of what the person says they want to see the doctor because of this, this, and this. Based upon that, the person at the front desk would say, well, it sounds like that may be, could be viral-related symptoms. There may be some difficulty with breathing, maybe some things we can do. It's not curative, it just has to run its course. Nurse practitioner or PA is very effective in that.
So I can't say, I don't want a nurse practitioner, I want a doctor.
You can talk to your doctor about that. It may change the availability of you getting to see the doctor. Now, the physician in this book wrote, he had two things that he would say. He said, if the patient came to the office, and a lot of times if you come in, let's say I come in with upper respiratory problems, and it turns out to be a virus. And they may give me something to help with my breathing. It might be an over-the-counter. It may be something they could get, like a cough syrup or something like that. And then the physician assistant and nurse practitioner would say, if you're not better in 3 days or you get worse, we want you to come back. Now, return calls back for this physician that wrote this book go to the physician. So if a person doesn't get better, they're not coming back and seeing the nurse practitioner, not coming back and seeing the physician assistant. They're going to come back and see the doctor. Or every practice knows their patients that have extreme complex issues. And based on those complex issues, those patients will go exclusively to the physician. These may be patients that have multiple chronic diseases and have been in and out of the hospital quite a bit. And those patients will be directed to the physician at that appointment. Other criteria by other physicians, it's up to them because we let them manage their practices. The main thing is they don't want the nurse practitioner or the physician assistant going above where their comfort level is. In other words, physicians are comfortable with PAs and nurse practitioners doing certain things, but they know there's a limit on what they're capable of based upon their training. So they're cautious not to have them push the envelope, if you will, to do things that they don't want them or feel they're prepared to do.
So this last thing you said.
There's no limit.
So until I get sick, and 3 days later, I'm dying.
Well, maybe not in that manner of speaking, but yeah. Yeah, and I would say that, let's just say this, nurse practitioners and PAs are a necessary component because there aren't enough physicians. So you want, that's not enough, yeah. So we want our physicians working what we call top of license. So their training is much different than a nurse practitioner or PA, so top of license for physician. In other words, we'd rather have the physician focus on some more complex patients than flu symptoms or the junk that's going around the community this week type things. Until we find out it's not that, then it's something different. So we want to have the more complex patients seen by the physician and the less complex cases seen by the nurse practitioner or PA until they're determined to be something more complex, which is what they screen to do.
Excuse me, but wonder if they don't, that nurse practitioner doesn't send you back to the doctor. Because just here recently, I've been back to the nurse practitioner twice, and I still got no better. I still haven't got any better. I mean, she's had me on antibiotics twice, and whatever, for sinus infection and all this, and it's still no better, and it's still doing the same thing. So then what about the doctor then?
Yeah, I would say when you call your physician office, say, I've been back twice and I'd like to see the doctor, because you have to remind them that you were just in. So they'll make sure that they can find out what's going on, because if they're not catching that,
I'm having chest pains and everything is not going, well, then that's another trip, that's just money. Go. I mean, every time you go,
yeah.
and they're not helping you.
But their goal is to keep you out of the hospital, so they'll do that. But if you're not getting the feeling that you're getting the traction with the nurse practitioner or the PA, then when you make your next call to the office, you can say, I was here on this date, I was here on this date, and I'd like to see the doctor this time.
My nurse practitioner used to have that.
Yes.
I got two things about the ER.
She sent me home.
Do the doctors
I
have a
ended up
dress
at
code?
ER the day after.
Yes, they do.
Okay, I was out there
I was
Christmas,
in so much pain.
and the doctor came in, I didn't even know it was a doctor. For one thing, she come in with a little bully attitude. She didn't even look at me. What brings you out here today? And I asked the girl that was taking my blood, I said, is that the doctor? And she said, yeah, well, I thought she was a maintenance worker the way she looked. And she talked to the computer the whole time. She never turned around and looked at me. And she asked me a question, and I said, oh, that happened a long time ago. It's still on the computer. And I'm going, yeah, that's not what her. I didn't want to be there either. But the only good thing about her was she kept me.
It sounds like she got some work to do.
She needed an attitude change. Her whole demeanor, her whole appearance did not look like a professional doctor.
Well, I'm sorry that happened, because that would not be the expectation of a physician or anybody seeing you.
And the other two doctors that I saw were very, very nice, and the nurses were nice. I couldn't ask for any better treatment, but that one, and the other thing is, I had a friend that took her daughter to the emergency room with back pain, and she couldn't even walk. And they kept her out there in the waiting room, I don't know how long. She couldn't hardly sit there. Don't they have a little area where they could have put her in a bed because she couldn't even sit up?
It depends. Now, they do triage every patient that comes in, and they will do vital checks and all the intake information about what's happening. At that point, that's where the patient probably says, I don't think I can tolerate to sit in the chair.
She sat there and cried. They sent her home with no pain medicine. She came back the next day with the ambulance, and they operated on her the next day. And the other thing is, they wanted her to sit on a bedpan. Well, she couldn't even lift her bottom up to get on a bedpan. Don't they have the other types of bedpans, like if you break your back or something that's lower than a regular bedpan?
Yes, they do, but I'm not sure with the stretchers and the ED whether those will work, or they have the bedsides they bring in.
Well, if you've got a bad back and you can't even walk and you crawl, it would have been a little bit nicer to her instead of sending her home with no pain medicine or nothing. You said, well, we don't have a bed for pain.
Yeah, if you could, not now, but if you could give me the name of that person that came in, I'd like to look at that case when I go back.
Well, I'll ask her and see if she wants to give you the name.
That's good. That's good. We appreciate that.
Question over here.
Has dementia. And in Fayette County, and I've been talking with Patrick, and I've talked with Angela, we're interested in setting up a program for people with dementia, doing art, music, physical activities. But I'm excited about the PACE Center. What are the qualifications for getting somebody in, just say for day activities?
Sure. And the PACE Center, again, is the West Side Center where County Market and Cub Foods was. That program is for nursing home eligible patients. In other words, it's not for people that aren't at the nursing home level of need. In other words, it's usually for people who are being cared for at home by a family, and this is an opportunity for them to work with the PACE Center in continuing to keep that family member at home. So it is really just a day center, Monday through Friday. So it's not an overnight. People, you don't have to go every day either. A family could bring their loved one to the center every day and drop them off. They'll take care of all their meds, all their foods. If they need therapies, they'll do the therapies. If they don't seem to be feeling good, there's a clinic there right in the building, and a physician or nurse practitioner will see them to see that there's not a pneumonia developing or something like that. And then the family comes and picks them up at the end of the day. So they don't have to bring them every day, but it's a way of having the family have additional help. Plus, we provide all of the care that that individual needs. So it's a little bit of a unique program. So it's a substitute for being in a nursing home, and it's to enable people that are already caring for individuals and their family at home, or people that are at that point with a loved one and not sure what to do, to consider using the PACE Center as a resource and seeing if they can manage their loved one at home with PACE involved in caring for them during the day.
Okay, a couple of things. Will they provide transportation from the outlying counties like Fayette?
Yeah, there is transportation, and I don't have all the particulars on that, but there will be transportation available. So PACE Center is, they're not new. They've been around in California back in the 70s, and they just are newer to this area of Indiana. And you work with Medicare, and Medicare gives us a block of zip codes. So we are the exclusive PACE Center for an area of zip codes in a radius that's probably about 25, 30 miles. That's how patients get assigned to a PACE center, is based on their zip code.
How is the payment then? Is it Medicare covered? Is it private paid?
It's Medicare covered. So this covers everything. In other words, everything flips over into PACE, so medications are included, meals included, therapies included, visits to the doctor included, visits to the emergency room included, inpatient admission included, diagnostic work included, labs, x-rays, so forth. So it's all-inclusive care for that person.
Is there an evaluation then they have to go through?
Yes, and I don't know all the particulars on that, but individuals are screened for eligibility, that this is a good center for them and it is equipped and they meet the guidelines for eligibility. And then we're going to have some open houses starting in April to introduce this more completely to the community. We know that the word PACE is a new word, which means Programs for All-Inclusive Care of the Elderly. Programs for All-Inclusive Care of the PACE. That's not my name. That's what the government calls it. So PACE centers, you can actually go online and Google PACE centers, and you can see a lot more of what I'm describing and how they work. But PACE is a federal named program.
Because what I would be interested in, as well as sharing information, would be the day program, so that he would get socialization and some of the things that people with dementia.
Yes,
And
and
that
that,
gives me a break.
yeah, and that may be very effective. Absolutely, could be a very good program for him. Yes.
How are the urgent care facilities supplied? Do they all have doctors and nurse practitioners, or?
Yes, they had doctors and nurse practitioners. The doctor is there for a portion of the day, but the doctor does supervise all of the nurse practitioners or physician assistants in the facility. And the thing about urgent care is we don't always know what's going on with us. We think it might be something small and it's something big. So their challenge is to make sure that that person presenting to urgent care really should be there. Sometimes it should be at the hospital. So things like laceration. A small laceration can be just fine in an urgent care center, but a larger laceration would not be. Or a laceration that maybe involves some foreign bodies, cut on glass with fragments. That's going to be a lot more of a specialized issue and need. Now they can do x-ray, so we have x-ray at urgent care, so they can x-ray those wounds to see if they're eligible for staying there, or they'll say, you need to be at the emergency room. And if the person can't be transported, they'll get an ambulance to transport them. A lot of times they also come in with headaches or somebody fell and bumped their head. And they come in, and if we're not sure what's going on, we need a CAT scan, we're going to get them up to the emergency room, get a CAT scan. So urgent care fits a need when you have those lower level symptoms. So this time of year, they're great for flu type symptoms where it feels like I may have the flu. If they think there might be a chance for pneumonia, they have an x-ray there so they can do a chest x-ray. Now, the one at Meyer is called Reid Ready Care. So it's a little more of a scaled down urgent care. So it's not the same as the urgent care that's off Waterfall Road right there across from the center we built. So it's right there in that corner. That is a fully equipped urgent care. The one at Meyer is a much lighter one, no x-ray there.
I have a question that concerned a hospital visit that my husband had. And in that visit, at his release, there were 7 medicine changes. He didn't get released till late on Sunday afternoon. Some of the medicine he had, they made a bunch of changes. Some of the medicine was so expensive, I could not believe it. And this was Sunday, and they're saying he needs to take one in the evening. My main question is there a procedure, some kind of protocol in place that whenever you have that many medicine changes and that many possibilities of medicine interaction, should there not be someone that goes over and says to me, Ms. Armstead, your husband was on this, but we changed it to whatever it is, and that it's important that it's taken at certain times. I have managed his medicine for a long time. I think I'm pretty good at it. At least my doctors told me that. So what I'm saying is, that was so overwhelming on top of the extreme cost. So I started where I needed to. We had an appointment set up to see a hospital follow-up. Went there, they asked me about his stay. I told them exactly how I felt. And they started the wheels rolling because they said, we don't want that. I've had a nurse from, the manager from 5 call, and they were all very cordial and all very helpful in what they felt was a need for something like I was saying. Is there a procedure? Is there any protocol for releasing people with all of that medicine? Just like he's elderly, I'm elderly, I thought, well, by 6 o'clock that evening, drugstores are closing. What the heck is a person supposed to do when he's very ill?
Yeah, you're right. And disease knows no calendar, so 7 days a week. I know the different CVSs and so forth close much earlier than they used to. There's not one open 24 hours in a day. But to your basic question of informed information about medication changes is extremely important. Medications are complicated. When you get over 2 or 3, it gets much, much harder exponentially to manage. And when they make changes to them, the last thing you want is to cause a medication error because there wasn't a good explanation on medications and the frequency. So somebody should have explained to you and your husband about the changes, just as you said. He was on this and we changed it to this. We added this one. We added this one. And the why. Why did you do that? What are you using that for? And then the instructions on, take one at night, take 3 times a day, take in the morning, whatever those instructions are. And they should have also given you a copy of the printout of those medications to show the frequency. But the explanation is more important than the piece of paper because that's where the questions come in back and forth with the person's skill to do. That's what's part of what's called med reconciliation. So in other words, it's part of what they're supposed to do and sit down and explain those medications to you and the changes they made because, again, the last thing we want to cause is a medication error because those can be very dangerous.
What was so problematic to me is that I was in the hospital on a regular. Now, he got released on a Sunday, And so I got a call, I went. The papers were done. I went to look for the person that would, they usually go over everything and tell you. But I asked those questions and she says, well, the medicine's been sent to your drugstore. Okay, so I, on the way home, said I better stop and get it because he had doses coming up. And he did very ill. I did not realize the exorbitant price of all of that medicine within an hour or two of the drugstore's closing. And they sent him home knowing he needs it and how late it was. I was not late going out there. I went pretty promptly. And then the nurse came in and said, I need for you to sign this. I said, I need to understand this. And let's talk about it, So she said, well, all your medicine's sent, and these are the medicines he'll need to take later. She was not rude, but she wasn't helpful.
Right.
My question again is there, because one nurse I talked to said that she's having the same difficulty with her parent. My question is there, what you said, reconciliation, that process?
No.
Is that a must? Do they have to do that?
Yes, yeah. I mean, in other words, everything they did for your husband there will mean nothing if the end result is there's confusion on the medications that are supposed to help him.
I'm still going through this, and I called the doctors. I called all the doctors, because it wasn't all of his doctors that he sees. It was some hospitalists that he changed some medicine. I called the doctor he sees, and he says, well, I don't really know if he needs that. So that was very, very confusing and very disappointing in that it's just like they had a list of medicine, they checked this one and we'll try this. It doesn't work for me. I'm not saying that. I know it all, but I have been dealing with his medications and his doctors, and I had a very fine doctor that I've seen for years. And when I went, it was like, well,
Yeah. Well,
it's a major concern for elderly people like myself that have all of that medicine that comes in on them and die from complications of medicine.
yeah, the medications anymore are very powerful, and to your point, are expensive. Even the ones that have been around for decades have now come into these extraordinarily high prices. And I would just tell you on that point, we go to Washington, D.C. every year and talk to our elected officials, meet with the American Hospital Association annual meeting folks, and go through these item agendas because prescription drug pricing is one of the top 3 issues right now and has been, and trying to get the folks in Congress to listen to the fact that somebody's making a lot of money on this, and they just recycle these medications that were going generic and they change the formula just a little bit to make it show up as a brand new drug. And then they have patent protection for several years and nobody can compete with it. And they can charge pretty high prices. So this is a process that's been going on over and over and over. And the American people are paying the price for this because it's profiteering to charge these prices. But the medication reconciliation process is absolutely part of what the caregivers need to complete. Everything they did doesn't matter if you leave confused on how to deal with those medications.
So there is a process that's in place, and if you were the patient or another patient comes in and that doesn't happen, what would be the first thing you should do? Refuse to leave?
Yeah, you see, I have questions. I don't understand how you've reconciled these medications. I need you to walk through this with me very carefully because I don't want to make a mistake. And so, and I would say the other side too, the physician doesn't want you to make a mistake because the therapy they're prescribing, the medications, are supposed to do certain things and they're expecting certain things to happen because you're giving them exactly as they want them to be given. And if you're not, then one of 2 things, either they're not going to get better or they're going to get even worse. So that's what they don't want to have happen. So if they're not following, if you're not following their instructions clearly enough, you don't want to leave. you want to say, I still don't understand this. Let's go back. I need to make some additional notes because I don't understand what you wrote here. I don't understand what this means. Can you still explain that one? And do them one by one by one. Make sure you're leaving there feeling you have a comfort level that by the time you get home, you know I can do this.
Again, I'd say, I think a lot of people don't know where their rights really stand at. In the hospital, and that Medicaid paper, oh, y'all pay for you, yeah, you better read it. Yeah, because you can do just what I was at, and I said, well, let me talk. I have a doctor, and I said, I gotta call somebody else, because the nurse says, well, it's all there, that's just a few changes in our life. It's not, I'm not satisfied, and then I tried to reconcile some of it. And then I just said, I will give him the medicine the way he was taking it when he left. And the doctor I saw said that was the smartest thing that he could do.
And I would also not exclude your family doctor as well. So if you leave there and you're feeling, I just don't know what all we're doing here, I would make an appointment quickly with your family doctor and say, my husband was just in the emergency room. I got all of these new medications prescribed. I'm not comfortable. I'd like to sit down with the doctor and go through what was done in the emergency room.
That's the point I was trying to make, that if it's not enforced and really reiterated over and over, that has to be, because it was not a very good situation.
Yeah.
And you asked about procedure, and so specifically about procedure, it would be the discharging nurse that has the responsibility, sorry. The procedure that you asked about, it would be the discharging nurse that would be the one that would sit down with you and make sure that you understood. And you said someone had asked you to sign that.
The papers were already ready because of, you know.
They would print the pages would be printed with the discharging meds. Yes.
I think they thought that was enough.
But I think, yeah, they really should be going through that with you, that list of medications. These are. And I don't think it's a bad idea to say, hey, I'm concerned, now I have these changes, now I'm concerned, our pharmacy is gonna be closing. You know, you can absolutely bring up those concerns with the staff, because you know, that is something to think about. And maybe, you know, depending on what time it is and what the situation is, and obviously I'm not a nurse on the floor, so, you know, but I can tell you that, yeah, procedurally, maybe that nurse didn't think about that the pharmacies are going to be closing, but boy, that is something that could be a real challenge for you. So it's for sure, I mean, you know, the best thing you can do is, you know, advocate, you know, in that situation and say, hey, I'm worried about this, because there are social workers and folks. I was a social worker on the floor, so I know that sometimes these things, you know, come up, and we do have to find sometimes creative ways of doing that. And maybe it's a matter of the social worker is calling your pharmacy to find out what time do you close, and okay, these are the things that they're going to be picking up, have them ready for, you know, that kind of thing.
Let me ask you this. If you have a prescription and CVS can't fill it out, can you go to the hospital and get that prescription? Because I've been taking it for a long time, and now all of a sudden, they're always out of stock, like they are right now.
We can do new fills. So in other words, if you came to the emergency room, you can get your prescriptions filled in the pharmacy 24/7. So they're all there. If you went to your physician and they prescribed a new medication, they could fill that. The thing we can't fill are the reoccurring refills on what we call maintenance meds. So we can't refill those, but you can get your initial prescription at Reid if you want. You don't have to. But if it's 11 o'clock at night, we're probably the only ones open in Wayne County, so we may be the only choice.
I got one more question. But for one thing, you guys, you're talking so much. When they're giving us the answers, we can't hear. I got hearing aids in, I still can't hear. I hear wrong. But my question is, I know y'all talk now. But my question is, are your surgeons, I'm Ben Clark, are your surgeons required to do so many surgeries a day? Everybody's got knee replacements anymore.
Yeah, thank you for asking that, but no, there's no quota. However, an interesting discussion on this came up just a few weeks ago. that they're predicting a 100% increase in joint replacements over the next 10 years. Now, why? Okay, now we have this age group of baby boomers going through the pipeline right now, and they're turning 65 at the pace of 11,000 per day. So 11,000 people are coming into the Medicare program per day. So that means just a milestone. When you get to be in the Medicare age, your body is reaching another point as well. And the joint wear from the type of work you did on your knees and your hips, it may mean that you already had knees and hips done, and now you have to do another set because you had them done in your 50s and it's now getting older, so the joints need to be replaced. There's also new techniques for joints. We have a new system called it's a Mako robot. Now, it's not a robot that you would think, like you watch what a robot does, not like that. But it's, yeah, oh good, okay, Dr. McClurg here. So it's one that perfects the fit of the joint. So in other words, it makes sure that the bone is matched exactly to the joint that's being fit onto the bone. So why is that important? Well, a better fit means a better heal, less chance for infection, quicker recovery, less pain. So we added that robot in there and that does knees and hips. So it cuts exactly the right amount of bone to fit the joint. So the increase is because technology's gotten better, and the fact that we are living longer and we are wearing out the joints. People need to stay home and suffer. You can take care of knee problems and hip problems now. Years ago, maybe that wasn't the case. But technology is much more prevalent, and then the cases can go quicker because if everything works well from the fit, that's one step that used to take a lot more time to get the exact fit during the procedure. Now that goes much quicker, that portion of it.
So you don't tell your doctor you need to do 10 today?
No, because if I did, I would go to jail. Because there's laws against that.
I just recently retired, and just going over all the information for Medicare is overwhelming. So my daughter is a benefits manager for a corporation, and she referred me to Retire Med IQ. And so I set up an appointment, went to the appointment, they started filling in information. Some of it they already had, and the customer service response is, you're in Richmond, Indiana, it's Reid, they're a thorn in our side.
Oh, wow.
A thorn in our side. A thorn. So,
Did they go on to explain why?
well, they said that a lot of the insurances that you could get that are really good, Reid will not accept.
But they still pay.
Did they say which ones? The only ones that were not in are Anthem HMO. We're not in the Anthem HMOs.
But they still pay. Why? Because I got, and I've been through Reid this past year, probably millions of dollars. And my insurance paid. They said, all you have to do is say, bill my insurance.
Yeah, now, I would say this. There are a certain number of contracts that were actually signed in with paper between the two companies, Reid and the insurance company. So there's a certain number of contracts that we do actually execute directly. I can't tell you how many other insurance companies put us in as a network provider without a contract, or you could come to us as an out-of-network provider. The best way I can tell you, if somebody says, is Reid in my particular insurance network, I say, go to their website and they'll tell you, because I have no clue if I might say, well, I don't have a contract with them, but they may have us listed as we're in. In other words, all that really matters to the subscriber, the patient, is that will my insurance work at Reid? And only their website will be able to tell you if it does or it doesn't. So that's the important part, is making sure that the insurance is there. So I don't know the reason for the comment, but we don't let insurance companies push around our patients or Reid. So we are very engaged with our physicians, insurance companies, to make sure that we are on the same page with information and how they want bills to be done and how they're handling adjudicating claims and what they're telling the subscriber about what we did or didn't do. So we call them out on that. So if they think they were a thorn in their side, I might say, good, I'm glad they do, because we're advocating for our patients. So that's our take on it. Now, if they have a different issue, you can tell that person to call me, and I'll find out what their concern is and talk with them directly about how we're a thorn in their side and find out what's causing that. If there's something we're doing wrong on our side, I want to take care of it. So if you want to get me a name or send me an email, and I'd be happy to follow up with them. And you had a question too.
Just real quick about insurance, another thing to find out is what's the out-of-network coverage. So, because sometimes maybe it's in-network is covered 80%, but find out what the out-of-network coverage is as well for that particular thing. Because sometimes the in-network and out-of-network is the same coverage.
Sometimes they're very different.
Yes. Yeah.
No, sir.
I think she had one question. Then I'll get you next.
About quotas, is it true that physicians at Reid are only supposed to spend 15 minutes with the patient?
No, it's based upon patient need. Now, they may have the appointment scheduled every 15 minutes because you have to put blocks in of time to schedule patients. But here's a couple things that happen. Some people are less than 15 minutes. Some people are longer 15 minutes. Some people cancel. Some people no-show. So in the ebb and flow of a day, it kind of works out that if a person goes into a 20-minute appointment, maybe the person right behind them was a no-show or canceled, and they can still keep on pace. On the other side, maybe somebody is urgently sick and they got a referral call to see a patient, can they get him in today from another doctor, and they'll work that patient in during the day. So the challenge is nobody fits into a nice 15-minute time slot. Some people are faster than that based upon the fact that they have fewer issues. You know, I have one issue today, I don't have many medications, I don't have any chronic diseases, my issue is very simple, clean, and out. Other person may have a lot more chronic diseases going on, several medications, and more than one problem to deal with, and that patient may take longer. So 15 minutes is not a hard and fast rule for anything. It's just a matter of how you book slots. And not all of them are 15 minutes, though. It depends on the type of physician, as well as specialists are all different. And new patients, too, are also different. If you're a new patient to the practice, your time slot is not going to be booked on a 15-minute time slot. It's probably booked on more like a 30-minute time slot for a new patient. Yes.
Yeah, I am observing that you are moving on practically every side of town. And you're expanding with the idea that you are going to be able to bring in more people and more efficiency. How effective is that on your budget? And how in the end process, the person who comes to Reid is going to have to bear some of that money that you are spending or expect to spend on your budget. And in a long while, we're going to be canceling on everything.
Okay. So I've been at Reid for 25 years. I was at Connersville for 5 years before that, in Lafayette, Indiana, 5 years before that, in Pittsburgh at a teaching hospital before that. My walk up until 11 years ago has been on the financial side of healthcare. So I've been the chief financial officer at Reid for my first 13 years at Reid, and now almost 12 years as the CEO. I was the CFO at Fayette Memorial, now Fayette Regional, now not there anymore, and I was the director of accounting at Lafayette Home Hospital and a staff accountant in Pittsburgh. So I've been in the financial side of healthcare for a long time. As a background. So I'm going to give you a little more financial depth than maybe somebody else that's not me might. So when I came here 11 years ago, 25 years ago, we had 1,100 employees. and we had the one campus where we used to be on 1941, and then we had a property across the street which was leased to a orthopedic group. That was it. In 1995, we had two facilities, the one that's no longer there and a building across the street that's now our wound healing center. We now have almost 3,300 employees, and we're in 8 counties. And it isn't because we were on some major push to expand. We were filling in the need in the communities that surrounded us. In other words, we're a certified primary stroke care center. In other words, if a person is having a stroke, they have 3 hours from the onset of symptoms to get to an emergency room in order to have the one and only one intervention they can have, which is TPA, which is a special drug that will bust up a clot for somebody having a stroke. If you miss the 3-hour window, you can't get the medication because it might actually harm the patient severely. So the ability to be at Reid's front door within 3 hours expanded our radius, because if we weren't doing it, nobody would do it. Other hospitals weren't big enough to do it. Now we go to heart. Probably about 15 years ago, all we did was diagnostic heart caths. We didn't do open heart. We didn't do 24/7 PCI, which is angioplasty, balloons, and stents when somebody's having a heart attack to open up a blood vessel. So prior to 15 years ago, if you came to Reid and you were having a heart attack, we have to stabilize you and send you to Indianapolis. Okay, now time. Yeah, time is heart muscle. So now we actually have put technology into the ambulances, not just our own, but other ambulances around, that will broadcast an EKG. So if an ambulance comes to the house of a patient that's having a heart attack or chest pain, let's say, and they put the EKG on them, we're seeing it real time. So when that patient is still in the home and they have the EKG leads on them, we're seeing it and we're reading it in the emergency room. And we're telling that ambulance driver, the patient's having a heart attack, we called in the heart team, we're going to take him straight to the cath lab. And the patient comes in. I've actually gotten a letter from a patient in Richmond that was having a heart attack, and he said, I was having a heart attack, I was brought by the ambulance to the Reid emergency room, I was wheeled through the emergency room to the cath lab where Dr. Hornack was holding the door open for me and read it. And that's called door-to-door time. So the door-to-door time is a measurement of how fast you can get a patient in from the time they arrive to your facility. And you can't get any better than that because time is muscle. So we get in there and we put a stent in or a balloon to open up that blood vessel and restore flow to the heart. So every hour you lose in that regard can damage the heart muscle. Same thing with stroke. So we've been filling in this niche that exists between Indianapolis, Dayton, and Cincinnati for the last 25 years. And that's caused this growth of our business to reach out into areas surrounding us to have access for patients that would have to drive to Indianapolis, Muncie, Dayton, or Cincinnati for potentially life-threatening issues. So that's what's caused our growth in our business. Technology has also been an additional issue because we've been able to bring on technology and add technology to our portfolio. So we were first in state to put in the Varian TrueBeam linear accelerator. So linear accelerator is for cancer care, which is radiation therapy. We were the first one in state to put in the technology that actually moves with the movement of the patient when they're getting radiation treatment. So why is that important? That's important because when a patient has radiation treatment, you're wanting to reduce the damage to the good tissues that surrounds the tumor. So we invested in that technology. Why? Because a patient will have a better outcome, especially when you're dealing with lung tumors. So you want to spare as much as the lung tissue that's good and just attack the lung tissue that's bad. So we've been advancing into these technologies with the goal of saying to our community in this region, for what we do, you don't need to go anywhere else to get better care or better access to technology, except for we don't do neurosurgery, so we don't have neurosurgeons go in and do brain surgery. We don't have a burn unit, so if a person was severely burned, we don't have the facilities to do that. Those are highly specialized. We're a level 3 trauma, but we're not a level 1. So if you come in with multiple fractures and a head injury, we're going to stabilize you and send you by helicopter, more than likely, to a level 1 trauma. And we don't have a children's hospital. We're surrounded by great children's hospitals. We have 2 in Indianapolis, we have Dayton Children's in Dayton, and Children's Hospital in Cincinnati. So we don't try to do what we can't do that's better in those centers, Indianapolis, Dayton, and Cincinnati. But what we do that they do, we don't feel we're second to them at all, because we invested in the same technology or better than what they have. So that's been our growth opportunity, that people don't need to leave the area we're in right now, our region, to get better care to go somewhere else for what we do. But we will send you out for something we don't do to any one of those 3 centers that has access to levels of care that we don't provide.
I just want to say, I know you didn't raise your hand, but in relation to that, I just want to say how fortunate we are that we have bought Fayette. I started Fayette's original social service department many, many years ago. So my heart is still, it'll always be Fayette to me. But we were really concerned that we were not going to have even an ER department. And this fellow here had to be shipped from Fayette about 13 years ago for open heart surgery. And the hospitalist at Fayette saved his life by their intervention. So to have Reid come into our community, do the things you're doing, we're thrilled. So we're glad you came our way.
Thank you. We're happy to be there, and we're glad we can help out.
It's very good.
Yes.
I have visited in residential inpatient hospice that is outside the walls of the hospital, one in Denver, Ohio, one in Indianapolis. Is there any chance we could get something like that here in this area?
We continue to evaluate that, and it's an issue of the ability to afford to do it without taking resources away from other programs. So the numbers that you need to have to sustain a center for hospice is one issue, and the other is the construction of the buildings themselves. Now, if you've been around to several hospices that we have traveled around and have visited, a big portion of what is necessary to run those hospice centers is based on donations. And you can see that probably in many of them we went to, there was some area where there were an entire donor wall of people that had made contributions to the hospice center to put dollars back into the program. So hospice is, to create a center that we feel is what we'd want to do, is a price point that's very high. And so you almost can't do it unless you have a large enough donor base to offset the costs of the building. So that's something we're continuing to look at. So if we have enough patient volume, we may be able to do it. But right now, so far, it's been coming into an evaluation that says not now. Yes.
I recently received a letter, I think it was on Friday, and it was from the Reid Physicians Associates. The letter was concerning a program. It says it's not Medicare or HMO. It's something they're implementing, and I meant to bring it because you don't understand. It's called a CMS or something.
I got 2, Barbara.
Yeah.
Here, you know what I asked you about.
What that is, it's a CMS program, but every person that is actually possibly Medicaid eligible or Part Medicare, what we're doing now is under Patient Financial Services you will be screened to make sure that a lot of people are eligible for this program, but they weren't aware of it. So every person that comes in for either financial assistance or has been at the hospital recently will receive those letters.
It's offering saying it would help you with, some.
And it says it should help you with Part B
You don't necessarily say that.
and some Part D. But everyone will receive that letter. So they started.
There's an acronym, they had some C something.
I got
C, something that was covering it, and it was, mine was from Reid Physicians Associates,
Okay.
and it's a program, and it said you don't have to go in it, but,
You don't have to, but if I were you, I would check, just make sure that this might be eligible for some assistance. So, with the exact with QMB, if you have a certain level of income, then it will pay for your Part B, and then of Medicare. Only Part B.
It's your $144.60 that comes out of your Social Security.
So hold on.
It's your $144.60 that pays for your Part B that comes out of your Medicare. That's what the QMB, as well as it reduces the cost of prescription medications. Yeah, so it is absolutely a program. It's CMS, you might be seeing on there, Centers for Medicare and Medicaid Services. That's the program, that's through its who it is through, pardon me.
And the bottom line is, a lot of people have never signed up for it, but we have a large population of people that actually qualify for it. So we want to make sure that people are actually filling out the information so that they're not losing out on that benefit.
Is that in addition to Medicare B?
It actually pays for your Medicare B. But it's income-based as well. You're still enrolled.
It doesn't replace.
It doesn't replace it. It pays for it.
You're paying for it.
No. So it's at state, it's through CMS, but it's through the state.
And I can help with anyone after that has questions about that, I can help.
And everyone stand up. Morgan Gunder is with, and seen Morgan before, and she's with Medicare, with Reid Health Alliance. So she can answer those questions. And we're going to have one more question. Anybody have?
Over here.
Okay, one of the biggest stressors for physicians, I think, is electronic medical records. What are you doing to support your physicians so they don't feel like data clerks and spending a lot of time at home doing electronic records?
Sure. There's several things. One is we started a program called medical assistants, or people sometimes refer to them as scribes. So the assistant can put in information that doesn't require the physician to feed the keyboard on. So those are entry-level positions. They have medical information on terminology as their training, and they work to follow the physician and keep in tune with how they want their information loaded into the EHR. Now, there's rules and regulations, and the government regulations state there's only certain things they can put in, and other things must be put in by the physician. So try as we can to try and shelter as much as we can of the input pieces that we'd like to take that time away from the keyboard from the physician, put it back to the patient. Government regulations stipulate differently on things that they can or can't do. So what we're seeing, though, in the software evolution is a lot more what's called smart phrases and things that physicians, when they say things routinely, like if you're a radiologist and you look at a chest x-ray, you might say normal chest x-ray. Well, even just typing that out can take time to just type that out. But you can trigger it through voiced activation by saying normal chest, and it populates in the record the full sentence of what you wanted to say. So what we are seeing is that the documentation still gets into the EHR, electronic health record, but it's not all typed in letter by letter each time on certain things where you can use these smart phrases that the physician themselves sets up once and then uses many. So a physician could have multiple different smart phrases, or smart phrases that leave a blank where they want to say left or right, that they can fill in that blank only instead of writing the whole sentence or paragraph out. So we are seeing technology to help reduce the time, but the relentless part of the whole EHR piece is the requirement of documentation that's demanded by regulation, not just by the government, but also documentation by insurance companies. All that feeds into, earlier what I shared was the degradation of physician resilience. And what you're talking about, the EHR, is one of the key areas where physicians feel that they're not doing what they want to do. They'd rather be working with patients than working with a keyboard, to your point.
I want to thank Craig. And also, the one thing that we neglected to speak on, when a lot of the questions that were brought up, please make sure that after you've been at the hospital, you always will receive a questionnaire. Please fill that out, because believe me, every single questionnaire is reviewed. If there are problems, it goes to our patient experience. We have a patient experience team, correct?
Yes, we do.
As well as Craig sees those things. And that's how we make improvements in the hospital, as well as often, if worst comes to worst, you can always call me and I can get you to the correct place. But I get calls all the time, and we have sensed that particular question or problem, and I don't know who to get you in touch with. That way, we would have a better outcome. So.
Hey Sherry, how do you know that if you fill that survey out, how do you know it's not you? Because you know, if you don't fill it out,
Right.
they'll call you and say, hey.
No, it's actually it's a number system, and so that it comes in a date. It'll have a date as well as it doesn't have Sharon Harlow on it. It would have just a number. So, but it'll make sure that you responded. But if you had a bad experience, you want to know that Marquita Chavis had a bad experience. So that way we can actually find out what went wrong.